Good morning. Whoa, sorry about that. Jesus. Um, I'm Dr. Paul Jones here, and I would like to certainly welcome everyone here today on behalf of Dr. Golzar, myself, as well as other members of the founding executive board here of the CVC. This is our 5th year, and we've come quite a long way. There is an exciting agenda and program that's been prepared for you, and I think that, again, you all will have a very, very exciting time and a very productive use of your time away from work and busy schedules and enjoy this very educational event here. We are very, very grateful, again, to have you here with us here in Chicago. Just to introduce the founding members of the CVC, Dr. Jaafer Golzar, who you all know, who is a phenomenal guy with a tremendous amount of energy and who actually had the original vision for this conference, got us together 5 years ago and say, hey, we need to do something in Chicago. And myself, along with Dr. Jack Chamberlain from Alexian Brothers, and Dr. Amir Matarjame, who's one of the clear pioneers in this arena, supported him and say, we're all on board and let's go for it. And the rest is history. Again, we're here in our 5th year, and we've had very, very successful conferences, and we continue to make them better and better as the years go by. To announce our supporting cast, however, we all know that it takes a team to have a productive outcome in any type of an endeavor, and certainly we have been very, very fortunate as the founding members of the CVC to engage our supporting cast. Dr. Patricia Thorpe, who you guys are all well aware of, is internationally renowned in the area of the management of venous disease. She has come on board to help us out in the past several years, and she's basically the venous program chair. Dr. John Dale Jenkins, a podiatrist, who certainly adds to our multidisciplinary platform and is a phenomenal, well-respected podiatrist in the city of Chicago here, has been invaluable in terms of helping us to put together a program that readily engages our podiatrists and again, it provides us that multidisciplinary impact on our patients and this particular program from an educational perspective. Additional members of the team is Wendy Ambrose Gavin, who is our nursing program chair, who's been actively involved in helping support us develop this program from the perspective of our allied health professionals, like nursing, and also Jill Jones, who's a radiology technician, who also, again, has been very, very valuable in helping support it with this program. The mission statement of the CVC, again, when we decided to put this program together, we got our heads together and came up with a true objective and plan about our true mission, and it is to deliver comprehensive, practical, and progressive education highlighting a truly multidisciplinary approach in the management of patients with peripheral vascular disease. Our agenda overview here, again, is fairly comprehensive, and we think it is unique. It runs 2 parallel tracks of an arterial as well as venous program. As you can see here, on the arterial side, we're going to have very interesting discussions and comprehensive interaction on the management of restenosis, various device therapy, which includes atherectomy, management of complications of disease. We're going to talk about interventions for various types of aortic pathology, both above and below the diaphragm. Renal denervation, which is a very interesting topic, as you guys know. We will have some time spent discussing that particular therapy as well as carotid disease, limb salvage with arterial occlusive disease, wound management, and complex infrapopliteal arterial occlusive disease. And last but not least, we have to talk about that painful topic of the business of medicine, where it was, where we are, and where we're going. On the venous side of things, again, a very comprehensive program that as well, we'll be looking at both the deep venous disease as well as iliofemoral venous disease like May-Thurner syndrome. We're going to talk about filters. We're going to talk about pulmonary embolic disease, lymphedema, as well as some superficial venous disease and cosmetic therapy, and also some live venous workshops. To complement our didactics, we're going to have some live case discussions and presentations. Dr. Golzar will be giving the first live case demonstration from Oak Lawn Hospital. That's Christ Hospital in Oak Lawn. And Dr. Miguel Montero Baker will be having a live case in Tucson, Arizona. Dr. Julio Rodriguez, who's a vascular surgeon out at the Phoenix, Arizona, at the Arizona Heart Institute. Dr. Saeed Hussein from Champaign, Illinois, as well as our beloved Dr. Mir Matarjame from Downers Grove will be having live cases. Once again, this program would not be possible without the assistance of all of you guys, so we certainly appreciate you as our attendees and your interest and support of this particular program. Our sincere thanks also goes out to our scientific committee, our international faculty members, both from abroad as well as local faculty members, and say last but not least, our commercial grant supporters, which obviously we need their financial support to put this thing together. However, given all the gratitude and attention to the physicians that made this possible, as well as the supporting allied health professionals and the commercial supporters, I think it's vitally important also that we pay some tribute to those folks that are really out there on the front line on a day-to-day basis that are not our real physicians, but gosh, Renee, where is she? I don't know if she's here or not, but Renee Golzar, I mean, she has really stepped up to the plate as our executive director. I mean, the first couple of years we had outsourced it, and we had a number of challenges, but since she's been leading the helm, we've had tremendous amount of success, and she's just been invaluable. So I think it's, I would be incredibly remiss if we did not acknowledge her role in putting this program together. The other unique thing about our program is an ultrasound-guided pedal access course, which will be on Saturday morning. Again, for those that have not been involved with this course before, have not even seen it, this is really a phenomenal opportunity for those of you that are interested in pedal access. I would also remind you, we have a phenomenal exhibit with our vendors out there. And you should spend as much time interacting with them and seeing the new therapies that are available by the various vendors. And you'll find also that if they can share with you other opportunities for educational experiences in addition to their new therapies and devices that are out there. So certainly take an opportunity to spend time with them. And last but not least, enjoy the beautiful city of Chicago, particularly in the evening. I think in the summertime in Chicago, gosh, it's a beautiful place to be, and assuming that the weather will cooperate with us. It's a little chilly today, but I think it's a phenomenal time, so we certainly would hope that you would have time and an opportunity to enjoy the city. There's a couple housekeeping comments I need to make before we jump into our actual program here. There's been a change in the agenda for today. Dr. Tom McNamara, who is scheduled to give a talk at 4:30 on acute arterial thrombosis prevention and management during lower extremity intervention. That talk is moved up earlier in the afternoon to actually 1:10. Everything else will be shifted down about 15 minutes. Dr. McNamara unfortunately had to leave a little bit earlier, so that talk will be moved into earlier in the afternoon. There's another talk which is scheduled to be given at 2:50 entitled Pudendal Artery Intervention for the Treatment of Erectile Dysfunction in Males. That talk actually will be moved over to tomorrow. Dr. Ajalu Chukua will be here tomorrow. Unfortunately, he's stuck in Dubai and will not make it here today. The only other comment I would like to share with our speakers is that it is vitally important that we are cognizant of our time. We are trying to really stay on a tight schedule here. You will be notified at the last minute of your presentation. There will be a flashing light up here. And from that point on, you need to realize that you have 1 minute left, and your slides will automatically default to our basically template slide. Having said that, I'm going to conclude my little intro portion, and let's jump into the meat of this meeting with our first presentation here. Will be Dr. Renu Ramani to talk to us about restenosis and DCB.
Thank you, and good morning to everybody, and it's a pleasure to be here. This is a little difficult when you're short to be able to see what you're going to talk about. Could I get, is this? Okay, that's my disclosures. Yes, it'll be a little easier because I can't see over the podium. So I'm going to talk about restenosis and DCB a little bit. Restenosis in bare metal stents, restenosis in drug-eluting stents, and drug-coated balloons, a little bit on that. So I think to start with, it is important to understand what happens when you put a stent in a bare metal stent in an animal. So what are the things that can occur? The first thing that occurs is there's platelet thrombus formation, there's inflammation acute. This is followed by formation of granulation tissue, chronic inflammation, and angiogenesis. So there is smooth muscle cell as well as endothelial cell proliferation and migration. Then there is deposition by the smooth muscle cells of matrix, which consists of proteoglycan and collagen. And then the type 3 collagen converts to type 1 collagen, which can shrink, polymerize, and remodel, giving rise to a narrowing or re-enlargement of the lumen. So that is healing, and this healing is complete within 4 weeks of putting in a stent, and I'll show some of the findings here. This is a very old slide. Many years ago we did this work, and we showed that if you look at this, you can, at 2 weeks, you can still see fibrin deposition, and then when you look at beyond the 2-week period, you can see that it is predominantly consists of smooth muscle cells. And when does proliferation occur? It peaks. It peaks at about 7 days, and beyond that, at 14 days, you see a sudden increase in the new intima formation. And this occurs because the fibrin deposition and fibrin degradation products, they allow the smooth muscle cells to proliferate, and of course, there are growth factors liberated from the inflammatory cells. So this is just to illustrate what happens at 24 hours, 3 days, you start seeing inflammatory cells coming in, and then at 7 days, you see the smooth muscle cells infiltrating and proliferating, and at 28 days, you see the matrix deposition and around the smooth muscle cells and full coverage of that stent. So this is what happens in the coronary arteries, and here it is in the human artery, what happens. Instead of things occurring within 28 days, here they take as long as 6 months. So it's very different because we do most of our work in juvenile animals and therefore in normal arteries, and those heal very quickly. Whereas when you do the same work in older individuals, in humans or in animals in older, they will take much longer. So this is to show that thrombus formation can be seen up to 30 days, acute inflammation again up to 30 days, and when do you start seeing granulation tissue? Not till 14 days do you start seeing smooth muscle cell infiltration, and by 6 months, that number of smooth muscle cells enlarge in large numbers and covers and leads to smooth muscle and proteoglycan deposition, which is shown in green, as you can see here. So what are the predictors that lead to when you put in a bare metal stent that leads to restenosis. There are three main factors. One is medial disruption. If you look at those that have medial disruption versus those that do not have medial disruption, you see the amount of new intima is much greater. On the other hand, if you look at strut penetration of the necrotic core, you again see much more new intima formation as compared to if you do not have penetration of the necrotic core. But the most important factor is the amount of inflammation. So if you have very high inflammation, which comes with injury, you will get more new intima formation in bare metal stents. So you cannot keep on enlarging that stent and thinking that's going to give you the best results. It may give you acutely best results, but long-term not true. So when we looked at our cases in the case of coronary arteries, and we divided them into three groups, 3 months to 9 months, 9 months to 18 months, and greater than 18 months. What we showed was the amount of percent neointimal alpha-actin positive cells, that is, the smooth muscle cells, they decrease beyond the 18-month period. If you look at neointimal cell density, similarly decreases beyond the 18-month period. Same way, if you look at the diameter stenosis, it peaks at early time point up to 9 months, then begins to decrease, and it's much higher beyond the 18 months. And this was well documented in living patients as well by the Japanese group many, many years ago. So if you look at a normal artery, restenosis processes and inhibitors, if you look at a normal artery, what happens? Platelet fibrin deposition, coagulation occurs, adhesion molecules and chemotactic factors are liberated. That leads to growth factor formation or liberation and cytokines. That then lead to smooth muscle cell proliferation and the conversion of contractile smooth muscle cells to synthetic smooth muscle cells. And that enters in the cell cycle of division. So we now have drugs that can actually prevent that proliferation, like the sirolimus group of drugs, as well as paclitaxel. And of course, we can stop the cytokines as well as by anti-inflammatory drugs, and we can also stop the coagulation, as you all know. So once smooth muscle cell migration occurs, liberation of collagen type 3, as well as proteoglycans, these then condense and form type 1 collagen that shrinks and leads to decrease in the neointima. So in stent restenosis in drug-eluting stents, why does that occur? And I'm going to very slowly give you, we divided our cases, in all our cases, into those that had greater than 75% narrowing versus and total occlusion versus those which had less, and that's essentially what I'm showing you in this slide. And if you look at what did we learn from this, again, if you look at the distance, interstrut distances were very responsible for the amount of new intima. The more the interstrut distances, the more the new intima formation. And the red line shows you the correlation between the amount of distance and the amount of new intima formation, which is much less if the distance between the two, and you can understand why, because the drug is not going to be able to diffuse that much and therefore lead to restenosis. So what were the predictors? We found that the predictors of drug-eluting stent restenosis were total length of the stent, the maximum interstrut distance. The predictors of drug-eluting stent occlusion were those of total length of the stent, as well as the medial tear length was very important, the amount of injury. So what have we found differences between bare metal stents and drug-eluting stents? Why is the neointima any different? What we found overall is the smooth muscle cells are much less in drug-eluting stents overall, but on the other hand, proteoglycans are much greater. So there's a real dichotomy in the way we see restenosis. The restenosis in drug-eluting stents rich in proteoglycans, fewer smooth muscle cells. Whereas on the other hand, bare metal stents have much more smooth muscle cells and much more collagen rather than proteoglycan. It heals faster. So drug-coated balloons, what do we see the difference in what are the requirements? For me, the requirements of drug-coated balloons is it must deliver a large quantity of the drug within seconds, must distribute within the media in a few days. The therapeutic drug levels must be maintained for at least several weeks. For me, at least 28 days to 90 days. Must allow rapid healing as compared to drug-eluting stents, and no need for long-term anticoagulation. Light microscopy must show biological effects, and I'll show what it looks like at 28 days in our animals. These, you know, are the various drug-coated balloons that are devices that are available, and most of them use paclitaxel. Almost all on the market use paclitaxel, which has a very toxic effect on cells. It causes smooth muscle cell death, as shown. You can see control showing many more cells as compared to paclitaxel. And it has an effect on the actin, it has an effect on vimentin, and it has an effect on beta tubulin. All those get congregated and the cell cannot move. The progression, in a sense of proliferation, cannot occur for one. Second, neither can migration occur because of the effects on the intermediate fibers. So drug-eluting stents are quite different from DCBs, and I'm not going to go through since I don't have that much time. And I just want to show you that if you give paclitaxel alone, it doesn't have that much effect. It doesn't stay in the artery wall for very long, just for an hour or so. After that, what you require is an excipient. Excipient is a requirement to keep the drug in there. So excipient is a must. And just to show here, you can see that once there is excipient, which was iodopramide, in the sequent please balloon, you can see that it persists at 72 hours, in this case, the experiment that we did. And we also show that drug-coated balloons have a problem, whether it's iodopramide or urea, that is just split off from during dry balloon inflation. You can see a large amount of the drug comes off, less in urea as compared to iodopramide, loss during passage occurs, and remnants on the balloon are left behind. So there are problems. We can't get rid of all of the drug. During passage, we lose the drug. It's very important to have balloon to artery ratio, which is more than 1:1. If you look at overall the drug release kinetics, you can see that sequent please and urea have a little higher drug levels as compared within the first hour or so, as compared to Lutonix balloon. And you can see that if you look at the impact balloon, it has in 1x as well as 3x dose, the total amount of drug persists up to 90 days and greater. So what are the histologic parameters that we should look for? We should look for to understand whether we have biological effects, that is endothelial loss, fibrin platelet deposition, if there's inflammation, the extent of injury, smooth muscle cell loss, both in the circumference as well as in the longitudinal axis. And the matrix replacement. We will see more proteoglycan deposition. As shown here, you can see the green, you can see smooth muscle cell loss because of the actin stain that has been done, and you can see fibrin deposition. So overall, it is important to see these biological effects of loss of smooth muscle cells. These are vascular changes that can occur in the distal beds, so it's important to also look at the distal beds, which will be important to determine if CLI patients are going to benefit from these or not. So that's how I would like to end it. Thank you so much.
Thank you, Dr. Ramani. That was an excellent overview and discussion on the restenosis and the drug-coated balloon therapy. Unfortunately, again, time was of the essence here, and in that same light, we would like to continue with our next topic of discussion, the science of restenosis, and Dr. John George will come and share light on the subject matter.
All right, thank you. Good morning, everyone. I'd like to thank the conference organizers for inviting me to give this talk. Having said that, I'm extremely humbled that I have to give a talk on restenosis after the world-renowned expert on restenosis, Dr. Ramani. But with that, I will focus on something slightly different. Here are my disclosures. In the era of full disclosure, I will state that I have partaken of food provided by just about any vendor to the cath lab. So that's my full disclosure. So speaking of restenosis, we heard a lot about restenosis, and Dr. Vermani talked about primarily restenosis with stents. And I want to step back a little bit and talk about how we've struggled with restenosis and peripheral arterial disease interventions. So if you look at total prevalence of restenosis and peripheral arterial disease at 1 year, you see that in PAD it's about 41% compared to coronary artery disease where it's about 15%. So you see that there's a significant difference between those two vascular beds, and that's primarily from drug-eluting stents. But why is it so different? Why is restenosis so different compared to de novo disease? And so if you look at this histology, looking at primary stenosis or de novo stenosis, you see that that's an inside-out phenomenon. The process starts inside and extends outward. You have cholesterol deposition, macrophage activation, vascular inflammation going from the inside of the vessel to the outside. Restenosis, it's an outside to inside phenomenon. You have vascular injury during the intervention that causes disruption, like Dr. Vermani pointed out, to the medial layers, to the adventitial layers, and then causes remodeling on the outside of the vessel, and that creeps inward with cytokine expression, smooth muscle proliferation, and then this tissue response, this aggressive tissue response that causes encroachment into the lumen of the vessel. We all know that vascular interventions cause vascular injury. Balloon angioplasty alone, we know that it causes denudation of the endothelium, it causes stretch injury, it causes dissection and creates fissures and platelet adherence. I have an animal lab, and we routinely do this where we create a model of vascular injury by using high-pressure balloon inflations in the artery to create restenosis. We know that this occurs predictably. Stents, as was pointed out by Dr. Vermani, you create laceration from the struts, you have platelet adherence, you have mechanical strain, and just having a foreign body itself causes injury to the vessel. And once you have this cascade of vascular injury and inflammation, you develop restenosis. So if you look at these slides that show a stent expansion in a vessel that has a calcified nodule, you see that the stent expansion is not necessarily uniform, and you see that the calcium prevents it from expanding uniformly, and that creates barotrauma to the opposite side of the vessel, and subsequently elicits that inflammatory response and restenosis. Directional atherectomy is really the only way we have currently in vivo to remove tissue and look for analysis in these in vivo samples. And so if you look at these atherectomy components on the left side of the screen, you see some markers of deep wall cuts. And so if you look at that under histology, when you see that rubber band-like effect, that's the external elastic lamina that's been cut. And the question is, what does that do when you get into the medial layers and when you get into the adventitial layers for the long-term effect on the patient or on the disease? Here is another one where you have components of vascular tissue, or vasovassorum, that again indicates that you have cuts from the deeper layers into the media and adventitia. Again, what does that, how does that impact the long-term follow-up and patency? And this is a study from Dr. Krishnan, who's here on the panel, looking at directional atherectomy and looking at the patency or restenosis at 1 year following cuts into adventitia or without cuts into adventitia. And so if you look at this, it was a total of 102 patients, various length of lesions using the Silverhawk atherectomy device. And you see that the restenosis at 1 year is significantly greater if you have cuts into the adventitia as opposed to no adventitia. That's 96% versus 15%. So clearly, adventitial disruption correlates with accelerated restenosis. We have one of our own investigator-sponsored research that's currently ongoing. That's hopefully that will hopefully be published soon. This is the HIPAC study that we did at our institution, looking at histopathologic characterization of chronic total occlusion, so not just de novo lesions, but looking at CTOs and using directional atherectomy to look at the tissue. And I apologize that this may be difficult to see, but that top graph shows you the thrombus composition of the lesion in the chronic total occlusion. And you see that the patients that presented with TLR, or target lesion revascularization, following the CTO intervention had more thrombus within the composition of that CTO. The second graph below shows the adventitial cutting. So again, you see that there's more adventitial cutting in the patients that presented with TLR following the intervention. And finally, the third graph at the bottom shows you the lesion length. And this we've known for long, that as the lesion length increases, the TLR rates go up as well. And that's presented here as well within the CTO subset. So what else do we know about the composition of these tissues? We know that vascularity also correlates with the stability of the plaque, and the question of vulnerable plaque and whether these are prone to creating an inflammatory response and then occlusion. And this particular study looking at vascularity shows that the thin cap fibroatheromas are more vulnerable as they have increased vascularity. And so again, that is a question that comes to play within these restenotic lesions, whether the degree of vascularity is high or low. Stem cells is an area that I've been studying personally for ischemic cardiomyopathy and peripheral arterial disease. And what we do know, while stem cells play an important part in regeneration of tissue, whether it be tissue or vascular cells for angiogenesis, we do know that in restenotic segments there's an increased expression of stem cells or markers of stem cells. And so the question is whether this plays a part in that neointimal hyperplasia that we see in restenosis. These stem cells linked to restenosis are isolated to the adventitial layer, and the question again is whether these are activated because the adventitial layers are disrupted. And there are multiple studies that show stenosis and restenosis and no restenosis depending on whether the adventitial layers were disrupted for activation of these stem cells. Other tissue factors that have been linked to restenosis, there's been recently some data that's published looking at PEDF, which is pigment epithelium-derived factor, that seems to be protective in TLR. So looking across the board in peripheral arterial disease and lesions that are de novo and restenotic lesions, it appears that if you have a high expression of PEDF, that there is a decrease in TLR rates. Whether these, and how are these protective factors elevated in particular lesions, it's still unclear, and that still needs to be elucidated. IL-6 is another factor, an inflammatory marker that is correlated with TLR, and so this is really a marker of lesions that present with target lesion revascularization and restenosis. And so you see that across the board in this particular study done by Dr. Carr that the restenotic lesions have a high expression of IL-6. I will go through this quickly because that will be covered later on the drug-coated balloons, and it's been talked about, and there are multiple talks coming up in the next sections talking about DCBs and what they do to this inflammatory process. Another factor is ROS expression, or really reactive oxygen species, and whether that plays a part in restenosis. It's still unclear, but there is some literature that supports that if you have high ROS expression, that these lesions are predictably going to restenose, and so they are the most vulnerable for restenosis. So that brings us to what makes restenosis such a difficult subset of patients to treat. And this is appropriately quoted in Nature in 2012. Restenosis is a complex disease that is not yet fully understood. Investment in the prevention of restenosis is worth much more than the treatment. And so that really is what we need to get to, where we can treat disease appropriately, but how do we prevent restenosis, which is the hallmark of TLR and the difficulty in treating peripheral arterial disease. I'll end with one final quote. This is said by Sir James McKenzie, who's believed to be the father of electrophysiology. He said, "There are 3 stages in the history of every medical discovery. When it is first announced, people say that it is not true. Then a little later, when its truth has been borne in on them so that it can no longer be denied, they say it is not important. After that, if its importance becomes sufficiently obvious, they say that anyhow it's not new anymore." And that's kind of the cycle that we go through with this. We've known about restenosis all along the way, and we've learned a lot about it, but we've come back to restenosis saying it's not new anymore, but there's still a lot to be learned in the treatment of peripheral arterial disease with mitigation of restenosis. Thank you for your attention.
Thank you, Dr. George. That was a great presentation. Our next speaker is a friend and dear colleague, Dr. Jim McKenzie, the vascular surgeon from New York, is going to share with us his insights from drug-eluting balloon therapy and the clinical trials. Is it really breakthrough technology or just another tool in the toolbox?
Well, good morning, and I'm glad to announce that the last quote was not from me, since he's been dead for about 90 years. Well, I've been given the opportunity, and I appreciate the opportunity to speak today, and the topic gives you my insights of what's going on, so I'll try and give some data and some projections as we move forward. These are my disclosures. As we look at the restenotic cascade, this has already been fairly well discussed, so I'll just kind of go. You're looking at it, as has been mentioned, over a period of days to months, and so this is something where you have to have an ongoing effect. And many of us that think about restenotic processes, generally it takes 12 to 18 months to see it moving forward to the point of becoming clinically significant. So the extracellular matrix protein creation and everything else is the late part of this process, but one we're really trying to inhibit to a greater extent. And that's where the anti-proliferative actions work. And looking at drug-coated balloons, again, as it was outlined already, you have the drug in conjunction with an excipient that allows the release of the drug from the balloon and on into the target vessel. And that's part of the secret sauce of trying to figure out what's the best way of trying to deliver the right concentration of the right drug to try and help inhibit restenosis. This is some of the earlier studies, again, showing the effect of concentration and trying to inhibit instant restenosis with a 28-day follow-up, so that's still early on in the restenosis phase. But it is something, again, showing that there is a positive effect when you come in and give the drug in the area of the angioplasty to try and prevent that acute response in restenosis. So I started, as is charged, I think, what would make this a breakthrough technology and versus just another tool? Well, if it's standalone therapy, if you could do it one time, didn't have to do anything else, I think that would be a breakthrough. If it came through, it had a long-term patency. If you've got, 60-day going out to 6-month patency, it's really not going to see something that's going to be effective, and we're going to say that's not a breakthrough. It has to be easy to use. It has to be economical. Again, if we come in and it's hugely expensive and prohibitive for our healthcare system, it's not going to be the definitive breakthrough technology. Has to be effective in multiple areas of treatment. Certainly, I think it will be a strong technology if it's effective mainly in the SFA, but if it's effective in the renals, the iliacs, the below knee, all that area, I think would make it a breakthrough technology. It has to, I think when I look at what's breakthrough technology, the drug-coated stents for the coronary, I think is something we really consider as breakthrough technology that has really changed how we're managing coronary artery disease to a greater extent. I think the advantage of not leaving a foreign body behind also makes it more impactful because you don't have to deal with the aftermath, as we just heard, about the stents and struts and diameters of struts and radial force associated with it. So what if it's just another tool? Have selective use, is only good in certain areas. It has an additive effect of therapy, so you have to do this in conjunction with another therapy. Limited area of use, if it's costly. It needs data supporting the use as it expands further, and it has a clear-cut advantage over other treatment options, but it's still not a standalone therapy. So if we look at the history of the drug-coated balloon, we all remember back to the Thunder Trier and FemPac, and we saw that there was a significant improvement with use of the paclitaxel-coated balloon relative to the uncoated balloon, with late luminal loss as well as the need for revascularization, or TLR, target lesion revascularization. So this started the interest in the United States of really, is there a role for drug-coated balloons in the treatment of patients with peripheral arterial disease, especially in the SFA. Now we come back and look at some of the more details as you go into this, and you can see the lesion lengths are relatively short in these trials we've already outlined, somewhere between 4 and 8 centimeters in length up to 9. You're going to find that there's going to be a moderate level of calcification. I think we all know calcification is one of the main things we have to deal with as we're treating with these more complex lesions, and of course chronic total occlusions. We've seen the slides where you've catheterized through a total occlusion and the impact of trying to do a balloon angioplasty in the aftermath of the residual plaque, the disruption of the external elastic or the internal elastic lamina and potentially the external elastic lamina, and then also the shifting of the calcium plaque itself. So these things are still limited in smaller lesions. I think if you went and averaged the patients that you saw with significant SFA disease, a 7-centimeter lesion is not going to be on the top of the bell curve. It's going to be off to the extreme, and you're going to see more commonly lesions that are going to be double or triple that length when you're dealing with the SFA. So what trials we have that are really moving forward? We have 2 balloons that are now approved here in the United States. The Impact SFA trial, and this was both a global registry as well as the United States pivotal trial, which has been completed. First, we'll discuss the prospective multi-center European and U.S. randomized 2-to-1 single-blinded trial. They independently adjudicated by both ultrasonic and angiographic core labs to give it independent evaluation, and a CEC that was independent to evaluate all negative outcomes. They had a DSMB for both studies and external monitoring, 100% of the source documentation. Scheduled to be followed for 5 years. And what they found with Impact SFA2 was that there was a 98.8% patency at 1 year in those patients treated with drug-coated balloons, compared to a 66.7, or about 2/3 of the patients had a patency with plain old balloon angioplasty. If you look at clinically driven target lesion revascularization, there was a 2.4% incidence of those patients that had restenosis that had to have intervention if they had the drug-coated balloon, and a 20% of those patients that had balloon alone without drug that had to have reintervention. So a significant difference between those patients treated with drug and those treated with standalone POBA alone. Now, one thing I do want to point out as we look at the toolbox question of this is there is a selection bias here. Because if you think about POBA alone, if I came through and presented a paper that had POBA at 67%, most of you would consider that's fairly high. If you look at the Viva standards and everything else, you're going to say it's going to be about 33%. So there's a bias here with a selection of patients that are going to do better with plain old balloon angioplasty. Reason for that, and we'll go into a little bit more detail, is that they had to have a pre-dilatation that didn't have a significant dissection, that had a residual stenosis less than 70% to be allowed to be included in the trial. So there's, again, selection that have a little higher result. You then looked at the global registry, and I'll outline this a little bit more, but this was a single arm study, much more broad, greater inclusion criteria. 1,500 patients were included in the global registry, 67 sites, and single and multiple lesions were included. They could have multiple lesions as long as they're greater than 2 centimeters, no short focal lesions, all task classifications. SFA and the popliteal were included, and instant restenosis, highly calcific vessels, and chronic total occlusions were included in the global registry. So that's a much more real-world type of study rather than the U.S. trial, which obviously was for FDA approval. We look at the results of IMPACT SFA versus IMPACT Global, in which you saw the 2.4% clinically driven target lesion revascularization rate in the SFA IMPACT trial. The global was 8.7. More complicated lesions, more extensive lesions, longer lesions, multiple lesions, in-stent restenosis, and CTO. So I think even though you look at that parameter, though, an 8.7% clinically driven target lesion vascularization rate at 1 year is a very, very good outcome. You also then look at those patients that had clinically target vessel revascularization was a geographic miss. It was slightly higher in the SFA trial, US SFA trial at 4.3% and 9.5% in the global trial. The main other thing is you then look at Levant, which was just published this month in the New England Journal. This had 54 sites, 2-to-1 randomization again, same Rutherford-Becker inclusion criteria 2 through 4. Greater than 70% lesions in the SFA and or including the popliteal. Lesion lengths up to 15 centimeters, slightly longer. And again, they had to have that successful predilatation, no flow limiting dissection or need for stent, and they had to have less than a 70% residual stenosis after the predilatation to be included in the trial. The results came out, and basically if you look, and this is out of the New England Journal, those patients with the drug-coated balloon did better at 1 year, but the curves are starting to come together compared to those patients with plain old balloon angioplasty. And then if you look at those patients that had to have freedom from revascularization, there's still an advantage for those patients with drug-coated balloons over plain old balloon angioplasty. And still a very high rate, and then close to 60% patency for POBA alone at 1 year. The other area, and I'll be discussed in more detail in a future talk here, atherectomy for anti-restenosis, so combination therapy. It's called DART, which is directional atherectomy with anti-restenosis therapy. So they use one of the directional atherectomy devices coupled with a paclitaxel-coated balloon, the Paxocath. And basically what they found, they looked at primary outcomes, clinical follow-up at pre-discharge, 1 month, 6 months, and 1 year. And the interesting thing about this, they actually had angiographic follow-up for the 1 year follow-up. 121 patients were enrolled. Again, Rutherford-Becker 2 through 4, greater than 70% stenosis. Very similar to what we saw with Levant, 7 to 15 centimeters, so short lesions were excluded, and normal reference vessel diameter. And if you look at lesion length, again, slightly longer in those patients receiving DART at a mean length of 11 centimeters. The drug-coated balloon alone was 9.7 centimeters, which was statistically significant, for showing an advantage or a disadvantage to the DARTs. And they also had a severe calcification DARTs group, which was a subset analysis that were not included in the primary analysis. Again, you had a significant incidence of calcification even in the standard DARTs group at 70%. The DCB arm was 74%, and severe calcification 25 and 18% respectively. So what they found was that they had a low rate of embolization, higher in the directional atherectomy group at 6%, none in the DCB group. There's a higher dissection rate at 19% in the DCB group and 2% in the atherectomy and DCB group as you go through this. 4% instance of perforation in the atherectomy group and none in the DCB alone. And basically, getting to the end, what they saw is that there was an overall advantage for combined therapy of atherectomy and DCB with duplex. And this is another point that's kind of interesting. As you look here, there really is not that great a difference. But when you go and use the actual angiographic findings, which I think is probably more the gold standard, you'll see that there was a significant advantage for those patients with directional atherectomy and drug compared to the DCB alone. So I think there's a distinct advantage, especially in the longer lesions and the highly calcific lesions, for combination therapy. So in conclusion, I think we have intriguing preliminary results for the use of DCB. I think we need to move forward with it. Evaluation for diverse treatment groups required to give our best utilization. I don't think it's going to be all treatment lesions should be treated with it. I think there's a recent change in outpatient reimbursement favors the use of DCB, so it's not a financial hindrance on your institution. And my current use is in complex cases in-stent restenosis, long lesions, calcified lesions, and in combination therapy with atherectomy. And further studies are going to be required for below the knee, as well as use of other agents in different concentrations. I thank you for your attention. I look forward to questions.
Thanks, Jim. That was a great presentation. Are we ready for our live case? We're going to move on to along our agenda here, and we have a live case that's being transmitted from Advocate Christ Medical Center. Dr. Jaafer Golzar has a case of infrainguinal arterial occlusive disease and in-stent restenosis, if I'm not mistaken.
Oh, shit. Good morning, everyone, and welcome to Advocate Christ Medical Center. We're transmitting live today. We had a great team for you here today. We have a great case for you. Unfortunately, we had a couple of problems. Of course, Murphy's Law. We had a couple of problems with our video, so we're going to try to do the best with fluoroscopy. But let me introduce our team first and foremost. I have right next to me Dr. Tom Levin, who's one of our senior partners here. I have Jill, who's our radiology tech. Steve is our nurse. Walter is at the helm taking care of us, and Tom is here as well, who's also running for us and doing a lot of hard work. So we appreciate you guys being here. We've been holding off for a couple of minutes, so we heard Jim's talk, really great talk. We're listening on Dr. Vermani as well, and great to have you both here at CVC this year. So we have a very nice case for you this year. What we have is a 64-year-old female, has a history of peripheral arterial disease. Actually, back in 2006, she had a leiomyosarcoma of the left thigh with extensive multiple surgeries and resection. And if our AV team can show you guys that picture, I took a picture of her thigh and it is going to be pertinent to this case, and that's why I want you guys to see that. So she had this leiomyosarcoma resected, and she had she was at an outside institution last year and had a revascularization of her left SFA. She had drug-eluting stents placed in her left SFA, 3 drug-eluting stents. Then she came to me because within about 6 to 8 months, these reoccluded. So this is her angiogram. So we have an up and over sheath for you here, and this is an Ansel sheath. We took some initial pictures. You see an ostial or proximal SFA occlusion. You see the profunda femoral artery is open, and you see a small stump there. And let's go through the stents, and you can see the stents are completely occluded. Stents are occluded. Comes back in distally, right at the level of the popliteal, proximal popliteal. And let's look at our infrapopliteal vessels. So the anterior tibial artery, very sluggish flow, remember, because we have minimal flow here, but we do have subtotal occlusion into the anterior tibial artery, and the peroneal is patent to the foot, the posterior tibial artery is patent to the foot. So one of the first things I did, actually, let me rewind a little bit. One of the first things that I did was I did get a CT scan, because one of the concerns that I had was there any external compression from fibrotic tissue compressing that superficial femoral artery? I didn't see anything by CAT scan, so I was confident that we can at least go through this and revascularize this. We did a little bit of grunt work while you guys were speaking. So let me tell you what we did. We used an ocelot device to get through, and I really like the ocelot because it gives us ability to visualize as we're crossing the CTO. So I'm going to show you some images as we cross. And can you guys hear me, by the way?
Yeah.
I'm having a hard time hearing you guys.
All's good on this end, Jaafer.
Okay, good. Great. Okay, good. So what we have here now, I'm going to show you our our ocelot imaging. So remember, go ahead and turn that on for us, JJ. So remember, ocelot is OCT-guided CTO crossing device. Beautiful images here as we're crossing the CTO. You see the stent struts between 1 and 6 o'clock. Now remember, we have 3 overlapping stents. So what we're seeing is some overlap segments. We're seeing fibrotic tissue, and look at that. That's a very interesting spot right there where the vessel dilates up. The interesting part about this is what we see is most of the occlusion is in the proximal SFA. Then we have an area of heavy fibrotic tissue in the mid SFA. Then it opens up completely with just some thrombus, no fibrotic tissue. Then distal in the stents, it closes back down. And that's what we saw as we cross. And so that's really nice because that allows us to visualize the type of disease, the extent of disease as we plan our therapies. So I'm going to continue to go through these. And one of the other things I really like about the ocelot is you can cross with no fluoro. And so we did this entire case crossing the CTO with about 10 seconds of fluoroscopy just to confirm the proximal cap, the distal cap, and that's really what we did. Once we got through, we put a treasure wire down, and then we tried to get a balloon down, but then we saw that we had some difficulty in the mid-SFA, very fibrotic tissue there. So we had to pre-dilate that area so we could get at least an 035 Trailblazer down, and then we could get our wire down so we can deliver any further therapies. So at this point, what we've done is we've crossed with the ocelot. And there you see the ocelot image. Neil, could you zoom into the ocelot, to our fluoroscopy now? So there's our ocelot image, and then we have a wire down. And then this is the distal injection through the Trailblazer in the left popliteal artery. So now what I'm going to do is I'm going to turn it over to our panel, and what do we do from here?
I think it'd be
I can't hear you guys.
reasonable to start with an atherectomy. You know, the EXCITE data would support use of laser in a case like this.
Jaafer, this is Tom. I think the one teaching point to begin the discussion, I think it's key in approaching a long segment of restenosis like this to either use OCT or IVUS after you've recanalized it, because you do begin to understand
30 minutes.
the restenotic
Full
process.
pace.
Where is the predominant disease burden? As you demonstrated, it looks like there's significant disease before the stent, but then you also begin to understand the disease process within the stent, and I think that guides your approach.
No, just keep it on.
So my approach with this, Jaafer, would be to recanalize it, pre-dilate it, deploy a distal filter, and I'd approach this with atherectomy.
Yeah.
One question that I always come through, and I would do atherectomy there also. But for Dr. Ramani here, we always see people treating in-stent restenosis with POBA. And what actually happens to that tissue when you're blowing a balloon up? And then you get a nice pretty picture initially, but what happens to that tissue and how much recoil would you expect?
Is this, I will tell you all that happens is you compress the restenotic tissue because it is waterlogged, proteoglycan, so therefore you can compress it. But the problem is it'll all come back. So therefore, I do believe that in-stent restenosis, specifically total occlusion, you must do an atherectomy. Otherwise, you're not going to get anywhere.
This means
yes,
show me.
in
Yeah,
the
yeah.
middle of the total occlusion, there'll be thrombus. I also believe lysis should be done. So I think it's a combination because you don't want the clot to go distally either. So I think the combination is the better way to go.
Yeah, Jaafer, this
Great
is
points.
Eric.
I think
I was just going to say, this is exactly what the EXCITE study was about, and this is specifically what we were looking at, and specifically what Dr. Ramani just said. Balloon angioplasty alone on this does not work, and hopefully that we've proved that definitively now with the EXCITE data. But as you also mentioned, a large part of this is clot, and as Tom said, I always put a filter down on this, and I would atherectomize it and see where you're at, and probably use a drug-coated balloon in my practice.
Jaafer, this is Prakash. I would just play devil's advocate here. I mean, everybody knows I like atherectomy as well. But what do you think is the role for a covered stent here with the Reline study, and especially with the worry of clot going distal and also the tissue being present and just excluding it?
Absolutely. I think they're all very, very good options. So let's just review that. I think one thing that is overwhelmingly true that we know from multiple trials, from our experience, POBA is the wrong answer. So definitely you don't want to do POBA and in-stent restenosis. And the problem is I think people get complacent and they do that because it's easy. But I think removal of plaque is extremely important in in-stent restenosis. So as Dr. Vermani said, most of this is going to kind of come back as extracellular matrix. Second point is you can use a covered stent. That's absolutely a great option with the Reline study. Distal protection is very important in these situations because this is a lot of plaque, but a lot of thrombus as well. So all very, very good points, but I wanted to go over that. So unfortunately, we don't have two issues with our laser. So we don't have the laser available today. Second thing, when you do the ocelot, you're actually creating a 2 millimeter channel. Now I know we can do the 2.1 millimeter laser, and it'll probably give us a 2.5. But I like to do something maybe a little bit better, bigger, give us a little bit more of a lumen. I am going to go with atherectomy. So let me send it back to you guys. Would you use directional atherectomy, or would you use jet stream rotational atherectomy here?
I would use laser atherectomy.
Jaafer, this is Lou Lopez. One of the things I throw out
part of the multiple choice.
One of the things I
We've
throw
done
out.
a very small study in total occlusion in which we've done laser atherectomy, and the drug delivery seems to be better, and those arteries stay open in our animal models. So there's something, early results. This is not really large number of animals, so it's something to think about.
Jaafer, this
I've
is
done
Also, practically
both with
speaking-
the directional atherectomy as well as with the jet stream. Obviously, I have to say that it's contraindicated for in-stent restenosis with the directional atherectomy device, and so I've only done it as my own personal decision. But I think the other advantage is that if you use the jet stream device, you can go in, and most of these long segment stenosis has both intimal hyperplasia and thrombus. And so you can use the mechanical thrombectomy component of the jet stream, especially the larger jet stream, as well as getting luminal gain.
Yeah,
Great point. So, go ahead.
No, go. That's okay.
So, great points. So you're absolutely right. Directional atherectomy is contraindicated, but there are some studies, and the contraindication came from the early study, the Talon registry. But we do directional atherectomy in in-stent restenosis. We get really good results if you know how to use it, debulk it very well. You know when not to push. That's the important thing. As soon as you get resistance, you stop pushing. The other important thing, what I actually like, is at 3 o'clock and 9 o'clock, you actually know exactly where the stent is, and you know how much debulking to actually perform. So definitely contraindicated, but it can be used. I think we're actually looking at putting together a paper as well to go with the data that's already out there showing the safety of directional atherectomy within a stent. However, the other point was very well taken in terms of jet stream and with thrombus and plaque. So I think what we're going to do is we're going to go with the jet stream.
Jaafer,
What
can
I'm
I
going
make
to
one
do
comment?
initially
And
is,
I just want to throw one
Sure.
thing out there, which is that know what kind of stent that you're reopening. If it's a woven stent,
Correct.
directional atherectomy is a lot
very good point.
more difficult. But if it's a standard nitinol stent, it's really pretty easy to do directional atherectomy. However, I do like the jet stream because it doesn't catch the stent struts, and it also gives you, exactly as James said, some suction of some of the thrombus material that you get in these stents.
Yeah. So that's a great point. I'm going to go ahead and turn my back towards you. Please excuse me. But that's a really good point, because the last thing you want to do is never do directional atherectomy in a covered stent, because that will fail and you're going to have a lot of problems, and you will probably end up not being able to recover from that. So what I'm doing here is I'm going to go ahead and put a distal protection device in. We have an 019 bare wire, and what that is wire with the 019 tip to it, so we can recover this embo shield and confirm that is a 019 bare, correct? And then what I'm doing is I'm deploying a NAV6, large NAV6 here into the popliteal artery. Go ahead and open it on Jetstream, guys. Deploy a NAV6 into the popliteal artery. Now remember, we have already pre-dilated this just a little bit because we could not advance our trailblazer down because of the significant fibrotic tissue. So I've used a 3 millimeter balloon already, but obviously done no debulking at this point. So what we're gonna do now is use our Jetstream, get through this, and hopefully we get some good results. So, Eric, we have a little bit of downtime while we're talking, while we're setting up the Jetstream. Could you just quickly go over the EXCITE trial? And I know you're gonna be going over that more extensively, but it truly was one of the first studies comparing angioplasty with some type of atherectomy, and one of the first studies for ISR as well. So could you tell us a little bit more about that?
Yeah, the EXCITE study was the first randomized trial that compared atherectomy really to anything in the periphery for de novo lesions or for ISR. And I think that we went into the trial knowing intuitively that laser plus balloon was better than balloon, but I think until you have the data in front of you, you can't say that with certainty. So I don't think we were surprised by the outcomes, but now that we have the data, I think it's very, very clear that plain balloon angioplasty alone does not work for ISR. I think regarding other atherectomy devices, I think the most important point is you should probably do what you feel comfortable doing. Most people are not experienced with every single device. They may have a favorite device. Certain devices I think may work better than others, but you have to stay within your comfort zone. I don't disagree with some of the approach that you have here, but I think, again, you have to stay with what you feel comfortable with. But each device, I think, is going to have to go through its own trial phase to prove whether it works or not. I don't think just because the laser has proven to work that you can say the other devices also work. I think those are separate studies that require vetting.
Eric, I agree with your
Good
comments,
point.
but I think the key in this case, in most cases of in-stent occlusion or diffuse disease, is that you have mixed morphology. And not every atherectomy device is going to work equally well with mixed morphology. There are limited devices that are going to approach fibrotic disease, calcific disease, thrombus, which is, this is not heavily calcified, but as Jaafer said, there's a huge fibrotic component and a significant thrombus burden. So I think the choice of either Jetstream or laser atherectomy is the appropriate selection for this anatomy.
Yeah, I mean, laser is particularly well suited for thrombus. It's also particularly well suited for softer neointimal tissue. It ablates it remarkably well, and so to me, it's a great choice. It's directional. When you use the turbo tandem catheter, you can achieve lumens that are 4 to 5 millimeters in diameter, and instead of pre-dilating this, you can run a pilot channel through there with the smaller caliper laser, which will, again, I think, lower your risk of embolization.
Okay, so we're going to go, great points, thank you very much. So we're going to go ahead and get started. So what we're going to do, this is going to get kind of loud, but we have the Jetstream in place. And now remember, the Jetstream is rotational atherectomy with mechanical aspiration. So the tip is rotating at about 70,000 RPMs, and then proximal to the tip, we can go ahead and turn on, proximal to the tip, what you're gonna have is you're gonna have aspiration. So we're gonna go with blades down first. This is a 2.1. So here we go, we're about to engage the stent. I'm gonna move very, very slow. That's the most important thing here.
Jaafer,
So we're moving very slowly.
Jaafer, it's Prakash. While you're doing that, I just want to ask the panel, we have a lot of people who have got so much experience with atherectomy. What's their algorithm in choosing an atherectomy device? I know your case is very specific with ISR, but in general, in terms of the available atherectomy devices, I'm curious to start with Dr. Shimshak and come all the way down. And, what is your algorithm in choosing the devices? I know that, Tom, you spoke about the morphology. Do you do IVUS to evaluate the plaque and then decide? I mean, or what is your thought process in choosing the device in order to tackle the lesion if you're doing atherectomy?
That's exactly what I do. My strategy is to recanalize this with basic, angioplasty, subintimal technique, glide wire technique, pre-dilate, then IVUS, understand the morphology, extent of disease, look at luminal architecture, and then select the device based on that. If you're in question, I use Volcano, you can do VH analysis, so you know exactly what you're dealing with. And I like to pre-dilate after I've recanalized just to facilitate the effectiveness of the Jetstream device, which is my kind of go-to device. This is not really contraindicated for in-stent research. This is an off-label use of the device. There's been no data looking at this device in stents. But having said that, I've used this device for years for in-stent restenosis with tremendous results with IVUS guidance. So this is my approach.
John, what's your algorithm? Do you have any particular one that you use?
Yeah, I think it's quite similar. I'm not sure if this is working.
Never mind.
It's quite similar. I think the imaging component here provides a lot of information, and I think that was really helpful in seeing the ocelot images and knowing that there is thrombus involved. I am in particular intrigued by the proximal, the degree of fibrotic lesions in the proximal segment, proximal to the stented segments, and it brings to mind whether there was some degree of trauma to the proximal vessel in the previous interventions, or is this related to the surgical interventions that were performed for the sarcoma, or why do you have proximal disease, and whether the thrombosis of the stents is related to de novo lesions in the proximal vessel, which really makes the inflow to this vessel a primary issue. And I think that's where the imaging comes into play, and I think that gives you a lot of information.
Great point. So what we did is we went through the CTO initially, made a pilot channel with blades down, and now we're going to go with blades up. So you just push the button, the orange button on your device, and that's going to give you blades up. You'll hear a little beep, and then we are ready to go with blades up. Now this is going to get, go ahead, turn on, yeah. Now this is going to give us a 2.3 millimeter channel. We're going to go much slower. I'm sorry, 3.0 millimeter channel. We're going to go much slower here.
So as Dr. Golzar is working, what you're paying attention to is more the audible component with the device, which we can't appreciate during the live transmission. But you're paying attention to the pitch of the transmission, whether it's a high pitch and the load that the device interfaces with. If he hits that fibrotic point and the pitch goes up, there's tremendous load. You want to back off, drop down to a low profile again, and move through that. So technique is very critical with this device, especially for long segments of disease like this.
So, in other words, like what you're trying to do in order to let the device optimally debulk the vessel, you can't let it bog down and slow down in its rotational speed. So you have to approach the lesion slowly, and when you hit it, when you're hitting the fibrotic areas, you just have to go remarkably slow so that it spins at a high rate of speed and gives you a good debulk.
The other thing
now, another thing that you're seeing there is, even though it's a 3.0 lumen, when you go blades up, what you're seeing there is reverberation of the catheter itself. So that's going to give you even a little bit more. Now, what we're seeing is a little bit, as Tom had pointed out, go ahead. Tom had pointed out, you have to listen to the device. You hear the change in pitch. That means you need to slow down. And you hear that change in pitch right there. That means you're engaging a lot of plaque. So we're just going to slow it down. And sometimes we just have to even go back to blades down position. But we're going to just work on that while you guys talk. I wanted to mention that.
So when you see that reverberation, it's visible. You'll see the device on fluoro where it just sort of oscillates. That's a reflection of the load that the device is interfacing with. He's probably in an area where there's either no disease or thrombus potentially. And the key there is to not move quickly, but go slow. Let the device continue to aspirate, which is a key component of the effectiveness of this device, especially for thrombus.
I think going slow, and we actually do like a pecking action to it, so you kind of engage, disengage, try and let that aspiration. If not, you're more likely to have embolization with it too.
Now, I wanted to go back, Prakash, you mentioned earlier about the Realign study and using perhaps a covered stent to treat this, which is another effective strategy. I just wanted to add one caveat to that, and that is that even in those cases, I still debulk to make sure that the stent can fully open up once it's deployed.
That's a great point, Lou.
Tom, when you're doing a SFA, in-stent restenosis with a jet stream, what size device are you prefer?
It's an interesting question. I think for a long segment of disease like this, especially where there's a significant thrombus component, I would start with a 185. I generally start smaller. Even though you've pre-dilated, there's going to be such disease burden that there's going to be a lot of recoil. So I start small and then graduate up to the larger device. You know, the thing to remember, the IVUS data with this device shows that the luminal gain that you achieve is about 40% beyond the physical size of the device itself. So that's a reflection of the reverberation, the effectiveness of the cutter, and the aspiration.
50300 Pacific Extreme.
Eric, I have a question for you. You've been a big proponent of filters, and you've kind of led the way for all of us to realize the importance of distal embolization. And the question is, how often do you check the filter to see if it's getting filled? Is there any technique that you use to minimize your embolization while you're doing atherectomy? And what are your tips and tricks for that?
Yeah, I don't look because they all get full. So they're gonna get full. So you just have to accept that. And unfortunately, the biggest problem is, and this is something I've been trying to advocate strongly to industry, is that there are no dedicated filter devices for the periphery right now. And that's the biggest problem, is that we're forcing devices into places where they haven't been made or designed for. We need filters that have bigger volume of baskets, and et cetera, et cetera. The long and the short of it is these filters all get full. You can try and aspirate before you take them out. There's some things you can do. But the biggest problem is that they're simply not made for this territory. And so you put 5 pounds of thrombus down in there, and they're going to get filled up. So you end up pulling them out, and oftentimes there is some spillage over into the tibial vessels that you have to go and retrieve. But I think it's better than not using a filter. I think you catch the majority of the debris. But I absolutely use filters in all these cases. They have very, very high embolization rate.
I would add to that.
So what we're doing here is we actually have a Medtronic Pacific Extreme balloon. It's a 50 by 300. So you probably saw we performed atherectomy. We did a couple of runs, one with blades up, one with blades down. And now what we're doing, and so you see that fibrotic area right in the middle there. So now what we're doing is we're pre-dilating, preparing the lesion for our drug-coated balloon.
That's called
that
balloon.
That one little area is probably actually not fibrotic, because sometimes with the 300 millimeter balloons, you just have to be aware of this. You get a little bit of a wrap right in the middle, and I bet you when we move that, if we move that balloon back, you're going to see that at the same spot. So look at it, 25. So very good points actually that Eric brought up as well. And you know, when after Eric showed those excellent results after the Excite trial, I gave him a call and kind of got some tips and tricks because he is one of the masters and one of the PIs. Well, he is the PI of the clinical trial, but one of the masters of laser. So, you know, he told me exactly what he said. I know he's a funny guy and y'all laugh, but about not looking at the filter, but he's absolutely right, because if you look at the filter initially, you're gonna have no reflow. But if you wait about 5 minutes, he said, don't even look, wait 5 minutes, and then it's going to be gone. And a lot of it, what he explained to me, is not only was it thrombus, a little bit of distal embolization, but also microbubbles that go downstream and occlude off. And so that was a very great tip you gave me there, Eric. The other thing that you have to think about is when you use the NAV6, especially over the spider, the pores are much smaller in the NAV6 than in the spider. So that's going to get clogged a little bit quicker than a spider would. So just also be aware of that. So all we do is actually, we just keep working, just work a little faster.
Jaafer, while you're working, I'm going to make a strong pitch for people that are doing SFA popliteal work for intravascular ultrasound. If you really want to understand the extent of the disease that you're dealing with, evaluate the treatment modalities that you're using. There's no better tool than intravascular ultrasound to understand the adequacy of what you're doing and to guide you in device selection. And for those that are not using it, it'll open your eyes to the extent of disease in this vascular bed. And it's unlike anything you've seen, but it's a powerful tool to guide you.
I want to add another comment about using a filter, and The more I do this, the more important I think it is to use filters. And one of the things that I'll relate to you is that we don't have any cures for PAD. So most of these patients are exposed to multiple procedures. And even if you do a case and in your filter you just see a minor amount of debris, if you multiply that by multiple procedures, that's stuff that's going down in the distal vascular bed and including the small vessels in the foot that lead to ulcer formation and basically a dead foot.
Jaafer, it's Paul Jones here. A couple questions for you. It's a very interesting case. Going back to this patient's original history, now she had resection of a sarcoma of that thigh. Was there adjunct radiation therapy there as well?
Yes, she did get radiation back in 2006, and then actually, interestingly, she developed bilateral DVTs, had a pulmonary embolism, had IVC filter placement. So she had this long, protracted course in the hospital. She's just, just poor lady. She's a very young lady for this, but yeah, it was difficult. But she had her had her stents actually placed last year.
So her underlying pathoanatomy might be a full-thickness arteritis, radiation-induced arteritis, which is a different disease state from the typical atherosclerotic disease that we're used to treating here. And I think that might have an impact on, one, adjunct pharmacotherapy.
Go ahead.
Once you're successfully revascularized in this patient. So that's one question. Second question I have here, this patient had drug-eluting stents placed and basically failed that therapy, failed drug therapy in essence in addition to stent therapy. Why retreat with additional drug versus, in light of the fact that you have excellent runoff, looks like you have pretty decent proximal distal landing zone, why not use a Viabond and graft in this particular case versus retreating with additional drug therapy after you appropriately
So great point. So a couple of things I'm going to bring up. Great points. You're absolutely right. This could be radiation induced. However, it's going to be hard to know because she does have multiple PAD risk factors as well as being a smoker. So it could also be plain atherosclerosis. Now, in terms of covered stent, I don't do a lot of covered stent, and I think just going back to what Eric said is just all just what you're comfortable with. I love covered stents, but the problem with them is they don't, go ahead and come down, they come back as thrombosis instead of instant restenosis, which is fine, very easy to treat. Unfortunately, what happens in our institution is if a patient comes back with that, we have such a large institution that our vascular surgeons get contacted instead of actually going to the physician. So these are practical issues that not only we have to deal with, but other hospitals have to deal with as well. So what we do is we do a lot of atherectomy, drug-eluting stents. Now, that being said, your question about using another drug where you already have a drug. So, we have a drug, you're absolutely right, but we also have stents in place, and we have, I will take the Lutonix balloon. We have stents in place which obviously add another layer to the complexity of instant restenosis. So at this point, I don't feel comfortable leaving this with just balloon angioplasty results. For our institution, I don't think a covered stent makes sense, just personally speaking, but I think it's a good option. And we're going to be presenting the RELINE study later on, and so I think it's definitely a good option. So we're going to go ahead and proceed on with the drug-coated balloon. So we have Lutonix and a Lutonix drug-coated balloon, one of the first 150 millimeter drug-coated balloons that is going to be used in the country. We're using it today, so we're really excited about that, and we appreciate BARD in allowing us to get that early release of this new longer balloon. So here we have the drug-coated balloon, 150 millimeters. We're going to go ahead and go up. Now I'm going to go ahead and do it on the 014 wire that I already have in place. If this doesn't work, if we get caught on the stent struts, what I'll do is I'll take the filter out and I will go up with an 035 wire because this is an 035 balloon. Now remember, basic concepts on drug-coated balloons, try not to manipulate the drug coating. The Lutonix balloon, and I think the impact balloon, we don't have the impacts here yet, but the impact balloon as well have sort of a sheet that you can use
Hey, Jaafer.
Until you get to the sheath itself. Yeah, go ahead.
Jaafer, it's Paul. I was just wondering if we can squeeze in another talk so we can kind of stay
Sure.
reasonably on schedule, and we'll
Perfect.
come back to you for your final
Absolutely.
result, if that's okay?
Absolutely. All we're doing here is we're just going to do a couple of drug-coated balloons. Come back to us about 5 minutes. We'll give you final results.
Will do. Great case with a lot of interesting, I think, aspects of that case that we can discuss for the rest of the morning and into the wee afternoon hours here. But we'd like to get on with our agenda here and not get too far behind. And we'd like to bring our expert back up to the podium, Dr. Renu Vermani, to talk about the assessment of the calcium burden and calcium effects on drug-elution therapy.
Thank you again, and I do need to move because I can't see my slides. Again, so I want to start with what are the types of calcification that you can get, especially in the peripheral arteries or in arteries on the whole. So of course we know atherosclerosis leads to calcification. Second is, you all know medial calcification more than anybody else is in the peripheral artery, specifically the monkey burgers, medial calcification. And thirdly, there is the infantile calcification, which is very much like the monkey burgers, but it's different, it's genetically related. So I start with the coronary. You can see very nicely by X-ray the calcium, the areas of calcification in this radiograph. And again, you can see the fibrocalcific plaque, one from plaque rupture. Usually the sites of plaque rupture don't have that much calcification, not severe calcification like the one I'm showing you on the right, which is fibrocalcification, which is in a stable patient. Intimal calcification in the popliteal artery, as you can see again, this is mostly atherosclerotic, as I showed you in the coronary. In the coronary, you almost never see medial calcification, whereas in the periphery, it is very common. So here is monkey burgers medial calcification. You can get without atherosclerosis, although both can occur, and I'll show some examples of it. And here you can even get bone formation, just like you can get bone formation in the atherosclerotic vessel. You can see by OCT very clearly the areas of calcification. So this is idiopathic arterial calcification in infancy. This is a 20-day-old female infant. You can see the coronaries very prominently. You can see calcification in the aorta, and this is genetically related, and it's now well known. What are the mechanisms? So when plaques progress, how do we see calcification? So when you look at pathologic intimal thickening, which is the first lesion you get, and this has lipid pools, not a necrotic core, in the lipid pool areas you get microcalcification. These are usually less than 5 microns in size. Then come macrophage infiltration, and macrophages get again calcified. These now lesions are 5 to 15 micron in size. Early fibroathromas, you'll start getting calcification, which is now coalescing and forming little nodules of calcium. And that is called, eventually can form calcified sheets. In late fibroathroma, they occur in the abluminal surface. And then, of course, in plaque rupture, you see. But in stable plaques, you see the most calcification, fibrocalcific plaques. They are highly calcified with calcified sheets, and eventually you can get total occlusions, which from thrombosis. So when you look at early, as I described to you on the right, you can see Wankasa stain. You can see that those are black areas of microcalcification. It begins like that in all plaques, whether it's peripheral artery or coronary artery. And then they enlarge to 5 to 15 micron in size once macrophages come in. So if you look at calcification in sudden coronary death, you look at males, females. Males almost always have more calcification, except when you get into beyond the 70s. So when you look at age-related by decades, you can see that males have more than females. If you look at black versus white, you can see that whites have much more calcification as compared to the African American population. So is there a correlation between the amount of calcification and the amount of plaque? There's a very nice correlation with plaque area as well as with the amount of calcification. But lumen and calcification, there is no correlation. And below you are seeing as percent narrowing increases, you can see that the amount of calcification also goes hand in hand. So as the plaque enlarges, you see more and more calcification. So calcification in the peripheral arteries. This is work we're doing with CSI that has funded all this, and I want to show you some of the work we've done. This is in cadaver arteries, looking at angioplasty. We did angiography, we also did CT angiogram prior to actually doing the angiogram itself, and then we took the arteries off and did the radiographs followed by histology. You can see a very nice correlation where there's severe narrowing. You can see the amount of calcification by CT, and you can see that very well in histology, and again, showing that it can be towards the lumen and it can be away from the lumen, which in the peripheral arteries is not uncommon specifically. So here's another, just one single area. You can see it by CT, you can see it by angiography. You're unable to detect, but if you look at the radiograph, you can very clearly see it. And again, by histology, you can see. And again, virtual histology also showed the presence of that area of calcification, or by IVUS. You can see in the peripheral arteries below the knee, here showing that there is anterior tibial artery is totally occluded. You can see the branch point, you can see the CT angiogram, you can see the X-ray, you can see the angiography, nice correlation. And what is something to note here is there is not much medial calcification, at least at this point. So here, if you look at monkeybugs calcification on the peripheral arteries, specifically we did in the SFA in asymptomatic individuals. We just took the arteries out in about 15 arteries, and we looked at how much was the medial calcification. Good 50% of the SFAs showed us calcification in arteries that were not, in patients that were not symptomatic. So medial calcification in the peripheral arteries, not unusual. Here's medial calcification, again showing in the dorsalis pedis. You can see the radiograph. Its character is quite different. It is much more wraparound in the periphery of the artery. And if you look at by CT scan and you do an en-face, you can see how it is circumferential and it's towards the periphery. And I'll show example. This you can see very well. The black areas represent the calcification. And in the H&E stains, it is really the purple area which shows the area of calcification. Here's another example. You can again see, look at the wraparound. It has a different appearance in terms of differentiating, whereas in the case of atherosclerotic, it's very solid. Whereas in the case of medial calcification, it doesn't seem so solid, and you can see the feathery appearance, what I call, and you can see how it correlates very well with the histology showing circumferential calcification, medial calcification. So in peripheral arteries, these were legs that were removed during, because these patients had CLI or needed amputation from severe ulceration. Overall, 57% had, and of those, good 43% had above the knee disease. The rest of them had below the knee disease. And you can see, if you look at the luminal narrowing, good 50% of patients only show severe narrowing, but the rest of them don't have severe narrowing. Yet, if you look at medial calcification, good 50% of the artery and as much as 37% showed circumferential calcification that is greater than 76%. So it's very important. You can get poor flow just from medial calcification. So here's just to show the extent of calcification versus the amount of atherosclerosis. You can see the differences between the two. Now, what about calcified arteries? Do they show, will paclitaxel adhere to that surface of calcium? And as I said here, calcified peripheral arteries is similar to stones, and when wet, does not penetrate, the water does not penetrate into the interior of the stone, as shown on the right. So DCBs and calcification, we know from clinical studies that anti-restenotic drug effects are diminished in severely calcified arteries. And calcium acts as a barrier to the penetration of the drug. Modification of the atherosclerotic plaque by the Diamondback C360 orbital atherectomy device improved the drug uptake of paclitaxel. As much as 50% increase in drug uptake can be seen if you do orbital atherectomy, but I think we need to show that in patients that it really does work. So in summary, what I've shown you, there are 3 types of calcification. Calcification is common, accompanied all atherosclerotic arteries, no matter where they are. Asymptomatic individuals without peripheral artery disease, 50% show medial calcification. Both atherosclerotic as well as medial calcification are commonly observed in patients with peripheral vascular disease. Atherosclerotic calcification is more common above the knee, but medial calcification also occurs and is more common in diabetic and chronic renal failure. Medial calcification, to me, is more common below the knee from what we are seeing right now, doing work that we are doing in peripheral arteries. Bone formation is seen in peripheral arteries as much as 10 to 15%, so we must be aware that it can occur. So thank you so much for this opportunity.
Once again, a fantastic discussion, Dr. Vamani. We're going to go back to Dr. Golzar and to his case, which I think is really a fascinating case from a number of different perspectives. And I think we've had some great discussions on this topic and this case in particular. And we're running a little bit behind time, but we're going to kind of squeeze into our break session shortly. But I don't want to really take away the momentum.
Yeah, just tell them we'll show images after break.
How you doing, Jaafer?
Great, guys. So what we did is we went ahead and did DCB, and we put in a Lutonix 5, go ahead and get that down there. Lutonix 5x150, and we did Lutonix 5x100. Let me show you the shots, and then I want to show you what we had. So we did the Lutonix balloons all the way up, and then we had somewhat of sluggish flow down here. And so what I did is it was kind of running a little slow. So what I did is I removed the filter because I was concerned maybe the filter was clogged up. So we did the angiogram. We removed the filter, did the angiogram, and we have that spot right there. So what we have is probably a little dissection. Our disease ended at right around 36. So what we're going to do is just go back down here, treat that little spot. Probably there was really no disease there, so what I'm going to do initially is probably just balloon that and then use another DCB down there. And then what we'll do is you guys can go ahead and continue with your talks, and then I'll come back to you and hopefully get you guys final results.
Well, we'll come back
Go ahead,
after
Leo.
the break. How's that, Jaafer?
Perfect. That would be perfect. All right, Mag, up for me.
All right, we're going to take a probably like 10-minute break at this point in time. During this process, if there's any questions you guys want to come up and address the panelists, certainly feel free. Short of that, we'll be back in about 10 minutes. Thank you.